Welcome back to the deep dive. This is where we take those foundational, really dense chapters, the ones that build the backbone of your clinical knowledge, and we try to turn them into a clear, structured mental filing system.
Exactly. We're here to give you the anchors, the why behind the facts, and really the strategic context you need to make sense of the source material.
And our mission today is, well, it's absolutely critical for anyone in a surgical or diagnostic practice. We are doing a deep dive into Chapter 8, Diagnostic Imaging, from the 28th edition of Baily and Love, the big one.
It really is. And think of it like this. If your history and your examination are the compass pointing you in the right direction, then diagnostic imaging is the high-res satellite map. It shows you the terrain, the hidden dangers, the exact extent of the problem, and honestly, the safest route to get in and fix it.
You just can't practice modern medicine without mastering this map. And that's really the core theme for us today, isn't it?
It is. We want to move way beyond just knowing how to fill out a request form. This is about the principles of appropriate investigation. It's about managing the very real risks of contrast and radiation. And it's about developing a structured way to look at the images yourself.
Right. And just to be clear for everyone listening, this is our interpretation. It's a clarification. It's designed to be a high-yield framework, a kind of ready reckoner, and a revision aid.
We can't just read the entire textbook to you.
No. And we shouldn't. So please, use this structure, use these anchors, but always, always go back and read the original Baily and Love text. The depth and the nuance in there is just irreplaceable.
Knowledge is only valuable when you can apply it strategically, so let's start applying it.
Okay, let's jump in. The strategic approach. The text frames this as the surgical management funnel, which sounds very systematic. What's the anchor principle of this funnel?
The anchor is, well, it's simplicity and cost-effectiveness, but married to diagnostic efficiency. The basic rule is still, choose the simplest, cheapest test first.
Provided it actually answers your question.
Provided it gives you the definitive answer. Exactly. A great example is classic biliary colic. You know, that textbook presentation?
Yeah.
You don't jump to an expensive CT. A simple ultrasound will show you the gallstones, it'll check the bile duct. It gives you everything you need to plan that elective surgery. It's quick, it's cheap, and there's no radiation.
But I have to challenge that straight away.
Yeah.
Because that simple and cheap first rule can feel a bit outdated in some high-stakes situations, can't it? Isn't there a risk that you actually waste time and resources by following it too rigidly?
That's a fantastic point, and you're absolutely right. Blindly sticking to cheapest first can be a real problem. Imagine a more complicated abdominal pain. Maybe you're thinking small bowel obstruction, but there could also be a mass.
Right, it's murky.
It's murky. So if you do a plain X-ray, which is cheap, then an ultrasound, which is also pretty cheap but might be inconclusive, and then you still end up needing the CT scan anyway.
You've wasted hours, you've given the patient some radiation already, and you've delayed the actual diagnosis.
Precisely. In that scenario, going straight for the single comprehensive test, the contrast-enhanced CT, is actually better patient care. It's more efficient. You get all the answers in one go.
So it's not just about frugality. It's about diagnostic efficiency.
Yeah.
The real goal is minimizing the number of procedures and getting to the answer as quickly as possible.
That's it. And speaking of efficiency, the most valuable, low-cost, zero-radiation investigation is the one that people sometimes forget to even look for.
Prior imaging.
Prior imaging. You cannot overstate this. Checking the patient's record for an old CT, an old X-ray, even from years ago.
Yeah.
It's vital. It saves money, it saves radiation dose, and it can completely change your management. If you find a liver lesion on today's scan, but then you find an identical one on a CT from 3 years ago, that hasn't changed.
Well, your worry level just plummeted. You've essentially proven it's benign and stable without needing another big workup.
Exactly. It gives you the baseline. It tells you more than a brand new expensive MRI might.
Okay, let's use that logic. Here's a check-in question. A classic one for trainees on call. You've got a 19-year-old guy, textbook signs of acute appendicitis, migrating pain, fever, guarding in the right iliac fossa. Do you order a CT, or do you stick with the historical standard and just take him to theater?
Right. So pause and think about the modern rationale here. The old way, straight to surgery based on clinical signs, is still perfectly valid in some places, or if you are just 100% certain.
But that's not what usually happens now in big centers, is it?
Not usually, no. Modern practice has shifted towards getting imaging, usually an ultrasound in this age group, or maybe a CT.
But why? If the diagnosis seems so clear, why add the delay and the cost?
The number one reason is to reduce the negative appendectomy rate.
Oh, okay.
Historically, that rate could be as high as 15 or 20%. That's a lot of people getting an unnecessary operation. Imaging confirms the diagnosis, but just as importantly, it can reveal an alternative. Like terminal ileitis or, in women, a gynecological issue.
So it's about minimizing unnecessary surgery. It's a safety step.
It's a safety and a quality step. It boosts your diagnostic confidence.
That makes perfect sense. And that whole idea of ruling things out pushes us right into the next point. Collaboration. Ordering a scan isn't just sending an email into the void.
It absolutely shouldn't be. It's a partnership. That request form you fill out, you need to treat it like a formal consultation with a colleague, not just a tick box exercise.
So you need to give them the clinical details, your provisional diagnosis.
And most importantly, the specific question you need answered, not just abdo pain. It has to be query perforated viscous versus diverticulitis or rule out aortic dissection.
Because if the radiologist doesn't know the question, they can't pick the right protocol. They might miss the right contrast phase or the right sequences.
Exactly. And that's why you have to include the background stuff too. Renal function, allergies, LMP for women. It's all part of the safety check. And if a case is really complex, the best thing to do is often the simplest.
Just pick up the phone.
Pick up the phone. Or present it at the MDT meeting. Talk to the radiologist before the scan. That way, you ensure you get the highest possible diagnostic yield from the test.
Okay, so the scan is done. The images are up. A report is coming. But your job isn't over. You need to be able to look at the images yourself. And for that, you need a system.
You need a system. We use the anchor from the book, the 5 W's and 1 C, but it's easier to just break it down into steps. First, you verify the basics, the patient's label, the site scan, the date, the side marker.
The simple stuff that can lead to huge errors if you get it wrong.
Catastrophic errors. Then you assess the image itself. What's the coverage? Did we scan enough? What views do we have? And what's the quality? Is it rotated? Is it underpenetrated?
And only then, after all that, do you actually start interpreting.
Only then do you compare it to any previous imaging, and finally, you conclude based on a really detailed, structured look at the anatomy.
Let's make that structured look more concrete. What does that mean for something really common, like a simple x-ray of a leg after a fall?
It means you can't just glance at the spot where it hurts. You have to start with alignment. Are the bones straight? Then you meticulously trace the cortices, the outer edges of the bone, looking for a tiny break or a buckle. Then you look inside at the medullary cavity, then the joints, both above and below the injury. And finally, you check the soft tissues for swelling or foreign bodies. And you have to do that entire sequence for every single view you have.
That's the key. On both the AP and the lateral, that's the rigor that stops you from missing something subtle.
Exactly. It's your internal audit. Okay, so that brings us to our first key takeaway.
Key takeaway 1. Effective imaging starts with a strategic choice. The simple funnel versus a single efficient test. It relies on collaboration with radiology. Your request is a consultation. And you must have a rigid, systematic approach to reading the images yourself.
Now let's talk about the hazards, because these amazing tools have risks. We'll start with contrast media, the chemical co-pilot.
Right. And with CT scans being so common, we use a lot of ionated contrast. So what are the 2 big risks we need to manage?
It's twofold. First, the immediate risk of an allergic type reaction. And second, the more delayed risk of nephrotoxicity or contrast-induced acute kidney injury, CIAK.
Okay, let's ground the allergy risk. How common is a really bad reaction?
A serious reaction, one that needs treatment, is about 1 in 2,500. A truly life-threatening, catastrophic reaction is, thankfully, very rare, less than 1 in 100,000.
And most of these aren't true allergies anyway, are they?
That's right. They're usually anaphylactoid reactions. They look and feel like anaphylaxis, but they're not typically IG-mediated. And the biggest safety advance we ever made was switching to low osmolality contrast media, or LOCMs.
They're just much safer.
About 10 times safer than the old stuff. But standard practice is still to observe any at-risk patient for at least 30 minutes after the injection, just in case.
Now let's get to the big one, nephrotoxicity. This is all about the patient's renal function. What are the eGFR thresholds from the book that we absolutely have to remember?
This is non-negotiable. The highest risk of CIAKI is in patients who already have severe renal impairment, and the number you have to burn into your brain is an eGFR below 30.
30, okay.
Below that, you have to have a very, very good reason to give contrast. On the flip side, if the eGFR is over 60 or even stable and over 45, the risk of a clinically significant kidney injury is practically 0.
But what if it's an emergency? a suspected aortic dissection in a patient with an eGFR of, say, 25. You can't just say no to the scan.
You can't. The benefit clearly outweighs the risk, so you mitigate. The key is optimal hydration with IV fluids, usually saline, both before and after the scan. And the radiologist has to use the absolute minimum volume of contrast needed to get the answer.
What about that common question from junior doctors about metformin? There's always a panic about whether to stop it.
The guidance on this is much clearer now. For a standard intravenous CT, it's generally safe to continue metformin as long as the eGFR is above 30.
Right.
For an intra-arterial procedure, where you're injecting directly into an artery, the threshold is a bit higher, usually an eGFR over 45. Below those numbers, you talk to the physician about stopping it temporarily. But for most routine scans, stopping it is an unnecessary hassle.
Okay, let's switch to the other big contrast agent, gadolinium, for MRI. The risks here are different.
They are. Gadolinium is much safer from an allergic point of view, with reaction rates well below 0.1%. The big scary concern here is also tied to renal failure, but in a much more sinister way. We're talking about nephrogenic systemic fibrosis, or NSF.
NSF. You mentioned it earlier. It sounds absolutely terrifying. What does it actually do?
It's a progressive, sometimes fatal fibrosing disorder. It causes the skin and the underlying tissues to become hard and thick, like wood, but it can also affect internal organs, the lungs, the heart. Once it's established, it's incredibly debilitating and often irreversible.
So what's the anchor for preventing it? How do we avoid this?
It's simple. High-risk types of gadolinium are absolutely contraindicated in patients with severe renal failure. Again, that eGFR of less than 30, and in a couple of other specific groups like neonates. The newer, more stable agents are lower risk, but you still have to be incredibly careful. Scrutiny of that eGFR is mandatory.
Let's move to the other big hazard, ionizing radiation, the invisible risk. The book says medical exposure is about 15% of our total dose, but we need to understand how it actually causes harm.
We split the effects into two types. Type 1 effects are deterministic. That means they're predictable. They only happen above a certain dose threshold, and the worse the dose, the worse the effect.
Like a radiation burn.
Exactly. Or cataracts in the eyelids. This is really relevant for staff who work with fluoroscopy all day. That cumulative dose adds up over a career.
And then there's the one that patients worry about more, the random one.
That's the type 2, or stochastic effect. This is an all-or-nothing event. There's no safe threshold. Any exposure carries some risk. The main example is cancer development. The chance of it happening goes up with the dose, but the severity of the cancer, if you get it, isn't related to the dose.
We need to put this risk in perspective. Give us the anchor so we can grasp the scale of the decision we're making when we order a CT.
Okay, the lifetime risk of a fatal cancer from a single chest X-ray is tiny. About 1 in a million.
1 in a million, okay.
Now, compare that to a high-dose CT of the abdomen and pelvis. The risk there jumps to approximately 1 in 1,000.
Whoa. Let's just pause on that. 1 in 1,000. Now, you have to balance that against the fact that the general lifetime risk of getting cancer is about 1 in 3, but still, that's a huge jump from a plain X-ray.
And that's the ethical dilemma. For an 80-year-old, that long-term risk is basically irrelevant compared to finding out why they're sick right now. But for a 20-year-old with Crohn's disease who might need dozens of these scans in their lifetime, that risk accumulates. You have to weigh the immediate diagnostic need against that long-term risk.
And this is so serious, it's actually enshrined in law.
It is. In the UK, the IR-MER regulations put a legal duty on the doctor and the radiologist to justify every single exposure. Ordering a CT without a good reason is technically an offense.
That protection also extends to the staff.
Right.
Especially in theater with C-arm.
Absolutely. Staff have to minimize their exposure. That means keeping the beam-on time as short as possible. And it means recognizing that portable X-rays, the ones used on the ward, actually deliver a higher dose and lower quality image. They're a last resort.
And wearing your PPE. The lead aprons, thyroid shields, non-negotiable. Lead aprons, thyroid shields, lead glasses, and your personal dosimeter badge. Always. Okay, let's circle back to that case study. The 22-year-old with suspected Crohn's, who's going to need imaging for decades. Based on what we've just discussed, what's the strategy?
The strategy has to be minimizing that cumulative stochastic risk. So you prioritize modalities that use zero ionizing radiation.
Ultrasound and MRI.
Exactly. And for Crohn's disease specifically, MR enterography has become the go-to investigation for follow-up. It gives you incredible soft tissue detail of the small bowel. It can see inflammation, strictures, fistulae, all without the high repeated radiation dose of CT.
So even if CT is faster in an acute flare-up, The long-term management plan for a young person with a chronic disease has to favor the zero-risk options.
That is the core strategic principle. If US or MRI can answer the question, you have to choose them first, especially in the young.
Great. So let's have our second key takeaway.
Key takeaway 2. When you're using contrast, you have to scrutinize renal function. The eGFR anchor is 30 for CI-AKI and for the risk of NSF with gadolinium. For radiation, the goal is to minimize high-dose CT. Always prioritize US and MRI when you can, and be rigid about safety protocols for yourself and your team.
Perfect. Now let's get into the modalities themselves, the tools of the trade, starting with the original conventional radiography, the X-ray.
Right. The principle is simple. Differential absorption. X-rays pass through the body, and denser things like bone or metal absorb more of them.
So less radiation hits the film, and that spot looks white.
Exactly. And the anchor for reading any plain film is to master the 5 basic densities. From darkest to lightest, you have air, fat, soft tissue, bone, and metal.
And the big limitation is that all the soft tissues, the organs, the muscles, are mostly water, so they all look like the same shade of gray.
Right. That's the problem of superimposition. But they're still so useful, they're cheap, they're everywhere, and they're brilliant for bones, free air, and foreign bodies.
Next up, ultrasound. The operator spotlight. No radiation, which is its killer feature.
Its principle is the piezoelectric effect. A crystal in the probe vibrates when you apply a voltage, sending out high-frequency sound waves. Those waves bounce off tissue interfaces.
Like the edge of the liver or a gallstone.
Exactly. And the returning echoes are used to build the image. And the key trade-off you have to understand is frequency.
Higher frequency gives you better detail, but you can't see as deep.
Perfect. So you use a high-frequency probe for superficial things like the thyroid or a testes, and a lower-frequency probe to see the kidneys or the liver.
And then there's the genius addition of Doppler.
Indispensable. It uses the Doppler effect to look at moving things, usually red blood cells. It tells you the speed and direction of blood flow. You can see if an artery is blocked, if there's a clot in a vein, or if an area is inflamed because it has increased blood flow.
So what are the U.S. hallmarks? When is it absolutely the first choice?
It's cheap, it's portable, it's real-time, so you can guide a biopsy needle right to the target. It's the best for superficial structures and the first line for the biliary tree in most pelvic pathology.
But what are its weaknesses? What stops the sound waves?
Its 2 mortal enemies are air and bone. Sound just can't get through them, so it's no good for looking at the lungs or for anything deep behind a lot of bowel gas. And of course, it's highly operator-dependent. A good scan needs a good sonographer.
Okay, moving on to the cross-sectional map, computed tomography, or CT. This was the invention that solved the big X-ray problem of superimposition.
It's an elegant principle. An X-ray tube spins around the patient, taking hundreds of pictures from different angles. A computer then uses some very clever math to reconstruct all those 2D pictures into a 3D cross-sectional slice.
And the density in that slice is measured in Hounsfield units.
Right. With water at 0, air at -1,000, and dense bone at +1,000. This gives it far better contrast resolution than a plain film, and we boost that even more with IV contrast, often scanning in different phases.
Like an arterial phase to see the arteries and a venous phase to see the organs.
Exactly. That ability to time the scan to the contrast lets us find all sorts of different pathologies.
So what are the big CT advantages? Why is it the king of trauma and oncology?
Speed and coverage. You get a high-resolution map of the entire body in minutes. It's amazing for multiplanar and 3D reconstructions. You can create a 3D model of the blood vessels, for example. And for looking at fine bone detail, it's still the undisputed champion.
But the big shadow hanging over it is always the radiation dose.
Always. An abdomen-pelvis CT is like hundreds of chest X-rays. You have to justify it every single time.
Which brings us nicely to magnetic resonance imaging, MRI, the soft tissue specialist, with no radiation at all.
Right. MRI uses a huge magnet to line up all the tiny hydrogen protons in your body's water molecules. Then a radiofrequency pulse knocks them out of alignment.
And when they relax back into place, they give off a signal.
A signal that the scanner detects. And the image is built based on how quickly or slowly different tissues give off that signal. This is where T1 and T2 come in.
Okay, let's nail this down. The T1 versus T2 anchor. What's the simple way to remember it?
Okay. T1-weighted images show anatomy best. On a T1 image, things with fat or protein in them look bright. Water, on the other hand, is dark. So it gives you these really crisp, clear, anatomical pictures.
T1 is the anatomy map. Got it. What about T2?
T2-weighted images highlight pathology. The hallmark of almost all disease, inflammation, infection, tumors, edema is that there's more water there. And water is very, very bright on a T2 image, so pathology just lights up like a flare.
So if I'm looking for a tumor in the liver, I'm looking for a bright spot on the T2 image.
That's generally right. It's the water's bright sequence that shows you where the problem is.
And this incredible soft tissue contrast is why MRI owns certain areas.
It's the gold standard for the brain, the spine, bone marrow, and joints. And increasingly, for things like rectal cancer staging, MRCP for the bile ducts, and MR enterography for Crohn's disease.
But it has some big drawbacks, especially for a sick, unstable patient.
Absolutely. A scan can take 45 minutes. It's expensive, and it's incredibly sensitive to motion. If the patient breathes or coughs, the image is ruined. And of course, the giant magnet means there are strict contraindications for people with certain metal implants.
Finally, let's touch on nuclear medicine and PT-CT, the functional view.
This is a total change of perspective. Instead of looking at anatomy, we're looking at physiology or metabolism. We inject a tiny amount of a radioactive tracer.
Which is designed to go to a specific part of the body.
Right, like a tracer that gets taken up by active bone cells. Then a special camera detects the radiation coming through inside the patient and makes a map of that function.
Like a bone scan lighting up where there are metastases.
Exactly. And the most powerful version of this is PET-CT. It uses a radioactive sugar, FDG. Most cancer cells are hypermetabolic, so they gobble up this sugar.
And the PET scan shows you these metabolically hot spots.
And then it fuses that functional PET image with a normal CT scan, so you can see exactly where that hot spot is anatomically. It's incredibly powerful for cancer staging.
But the weaknesses are low-resolution images for standard nuclear medicine and very high cost and limited availability for PT-CT.
That's the trade-off. Okay, so that's the toolbox. Let's get to our next key takeaway.
Key takeaway 3. You have to choose the right tool for the job. Think X-ray or CT for bone and density differences. Think US or MRI for soft tissue and zero radiation. And think nuclear medicine or PET for function and metabolism.
Perfect. Now let's apply those tools to orthopedics. The hierarchy here is really clear. Start simple, escalate as needed.
So skeletal trauma, the absolute first rule of radiography.
You must have at least 2 views taken at right angles to each other, usually an AP and a lateral.
Because a fracture can be completely invisible on one view if the X-ray beam is parallel to the fracture line.
Exactly. Or a big displacement can be hidden. 2 views are non-negotiable. Now, if the X-rays are negative, but you still really think there's a fracture, like a scaphoid in the wrist or a hip fracture, you have to move on.
And that's where CT comes in.
CT is fantastic for complex fractures, especially ones that go into a joint, what we call intra-articular fractures. The CT gives the surgeon a 3D roadmap for putting all the little pieces back together perfectly.
Let's do a check-in on that. An elderly patient falls, they have terrible groin pain, they can't walk, but the hip X-ray is negative. What's the next step?
The next step, the most sensitive test, is an MRI. You're looking for an occult fracture, one that's not displaced. The MRI is brilliant because it will show bone marrow edema bruising inside the bone, which is the earliest sign of that hidden fracture. A VIST hip fracture is a disaster, so you can't stop at the negative X-ray.
Okay, what about wear and tear, degenerative and inflammatory joint disease?
Plain X-rays only show you the end-stage damage, like lost cartilage. For early disease, you need more detail. Gadolinium-enhanced MRI is the most sensitive for seeing inflammation in the joint lining, the synovium.
But ultrasound has a special role here too, doesn't it?
It does. With Doppler, an ultrasound can not only see the fluid and thickened lining, it can show you that it's actively inflamed by detecting increased blood flow. It's a dynamic test, which is a big advantage.
And for looking at the cartilage itself, the smooth lining of the joint.
The gold standard for that is MR arthrography. You actually inject contrast directly into the joint.
Wow.
It gets into all the tiny cracks and tears in the cartilage or the labrum, showing damage that a standard MRI would miss.
Okay, let's shift to something more serious. Aggressive bone and soft tissue disease, like a potential tumor.
The pathway is very structured. Step 1 is always a plain radiograph. It gives you the first clues about whether a bone lesion looks aggressive or benign. But if you suspect malignancy, the next step is mandatory: MRI for local staging.
Why is MRI so critical for the surgeon here?
Because it defines the battlefield. It shows the exact size of the tumor, how far it goes into the bone marrow, and most importantly, its relationship to the major nerves and blood vessels. This information determines if the limb can be saved.
And then you need to know if it has spread.
Right, so a bone scan or a whole-body MRI looks for other spots in the skeleton, and a CT of the chest looks for lung metastases.
Finally, in orthopedics, infection, osteomyelitis.
Again, MRI is the anchor. Plain films are often normal early on. Ultrasound can find an abscess to drain, but MRI is the most sensitive test for seeing the early inflammation and edema inside the bone and surrounding soft tissues. It's essential for diagnosis and for tracking the response to antibiotics. Okay, I think that's a good summary. Ready for the next takeaway?
Let's have it. Key takeaway 4. For the skeleton, the hierarchy is X-ray first, always 2 views. CT for complex bone and surgical planning, and MRI for everything soft marrow, muscles, ligaments, tumors, and infection.
Now for the chaos of the resuscitation bay,
Yeah.
imaging in major trauma.
And the number one rule here is different. Here, imaging must never delay resuscitation.
Absolutely. The primary survey, airway, breathing, circulation trumps everything. But in modern trauma centers, for a stable patient, the whole-body CT scan, the traumagram, has largely replaced doing lots of individual plain films.
The old idea of the CT being the donut of death because it took too long is completely gone.
It's obsolete. A modern scanner can do head, neck, chest, abdomen, and pelvis in under 5 minutes. It gives you a comprehensive map and finds injuries that X-rays would miss entirely.
But if the patient is too unstable to leave the resus bay, you still rely on those initial X-rays.
Yes, the portable chest X-ray and a single AP pelvis view. On the CXR, you need a system. Look at the lines and tubes, the airways, the lungs for a pneumothorax, the mediastinum for widening, the bones for fractures.
And the pelvis X-ray is a quick screen for a major source of bleeding.
A very major source. And a key thing to remember, if you see fractures around the front of the pelvis, you have to suspect a urethral injury. Don't just blindly try to pass a catheter.
Then there's the fast scan, the quick ultrasound check.
Focused assessment with sonography for trauma. A very targeted exam looking for free fluid, which you assume is blood in the abdomen and around the heart.
And the result of that scan dictates your next move.
It does. If the FAST is positive for fluid and the patient is unstable, they go straight to the operating room, no delay. If the FAST is positive but the patient is stable, they go to the CT scanner for a more detailed look.
And once they get to CT, what's the priority?
The head. A bleed in the brain is the most time-critical injury to find and treat. So the head CT should never be delayed by, say, getting detailed pictures of an ankle fracture.
And for the abdomen, CT is great for solid organs, the liver, spleen, kidneys.
Excellent. It can show lacerations and hematomas. Bowel injuries are harder to spot, but you suspect them if you see free fluid without a solid organ injury to explain it.
And let's not forget the role of interventional radiology in treating trauma.
A huge and growing role. IR can use catheters to go in and selectively block off bleeding vessels, a technique called embolization. This can stop life-threatening hemorrhage from pelvic fractures or a smashed spleen, often saving the patient from a huge open operation.
So a quick summary of the trauma workflow.
I think we can make this our next key takeaway.
Sounds good. Key takeaway 5. In trauma, CT has revolutionized assessment for stable patients, but resuscitation always comes first. The decision tree, fast, positive, unstable to OR, fast, positive, stable to CT, is all about speed and finding the immediate threat to life.
Excellent. Now let's move from trauma to the more general acute abdomen, starting with bowel obstruction.
The plain abdominal X-ray, the AXR, used to be the only test. What are the classic clues we still need to know?
You need to be able to tell small bowel from large bowel. Small bowel is central, and its folds, the valvulae conniventes, go all the way across the loop. Large bowel is peripheral, and its folds. The Hofstra don't. That's the main difference.
But the big warning is that a normal X-ray doesn't rule out an obstruction.
Not at all. Which is why CT is now the test of choice. It doesn't just show the obstruction, it often shows you the cause. A tumor, adhesions, a hernia.
And what's the one thing you were looking for on that CT scan to confirm a mechanical obstruction?
The transition zone. The exact point where the dilated, fluid-filled bowel upstream suddenly collapses into decompressed bowel downstream. Finding that point is the proof.
You also have to look for the really dangerous kind, a closed loop obstruction.
Yes, that's a surgical emergency. It's when a loop of bowel is trapped at both ends and it can lose its blood supply very quickly. On CT, you're looking for a very dilated U-shaped loop.
Okay, next up, perforation, a hole in the gut. The quickest test is still the erect chest X-ray.
It is. You need the patient to sit upright for at least 10 minutes to let any free air drift up to the highest point.
Which is under the diaphragm.
Usually under the right hemidiaphragm. You're looking for that little sickle of black air.
But again, if that's negative and you're still worried, CT is the answer.
CTs are far more sensitive. It can find tiny bubbles of air a plain film would miss, and again, it will often show you where the hole is.
Now for the critical warning, the absolute contraindication, the barium blacklist.
Yes. If you have any suspicion of a GI perforation or leak, barium contrast is absolutely forbidden. Barium in the peritoneal cavity causes a catastrophic chemical peritonitis, and it's often fatal. You can only use water-soluble contrast in that situation.
Let's quickly run through the common inflammatory conditions. Appendicitis.
We've said US is best for kids and young women. CT is preferred for most other adults. On CT, you're looking for a thickened appendix over 7 millimeters in diameter with surrounding inflammatory stranding in the fat.
Diverticulitis.
CT is the best test. It shows the inflammation around the colon and, crucially, any complications like an abscess that might need draining.
And acute pancreatitis.
It's a two-step process. An early ultrasound to look for gallstones, which are a common cause, but then you wait to do the CT. You should delay it for 48 to 72 hours.
Why wait?
Because scanning too early underestimates the severity. The most important sign of severe, life-threatening pancreatitis is lack of enhancement of the pancreas after you give IV contrast. That means the tissue is dead, it's necrotic, and that's a very bad sign.
Last one in this section, biliary and renal colic.
For biliary colic or jaundice, ultrasound is the first test, every time. It sees stones, a thick gallbladder wall, and dilated ducts. For renal colic kidney stone pain, the modality of choice is a non-contrast, low-dose CT KUB.
Non-contrast is the key part there.
It's vital. The IV contrast would be bright white, and so are the stones, so you'd hide them. The non-contrast CT makes them pop right out.
Fantastic. That was a whirlwind tour. Let's have the takeaway.
Key takeaway 6. For the acute abdomen, your first priority is to exclude life threats like perforation and ischemia. Then you localize the problem, find the transition point in an obstruction or the source of inflammation. And remember, the barium blacklist rule is absolute.
Perfect. On to our final section, imaging in oncology. This is where imaging has completely changed how we manage cancer.
Absolutely. Accurate staging with the T&M system is everything. It determines the entire treatment plan, especially whether a patient gets chemo or radiation before their surgery.
So let's start with T-stage, the local tumor. CT and MRI are great for advanced tumors, but for early-stage gut cancers, what's the best tool?
For that, endoscopic ultrasound, US, is superior. A probe on the end of an endoscope gets right next to the tumor. It can see the individual layers of the bowel wall, so it can tell you exactly how deep the tumor has invaded. That's crucial for deciding between a small endoscopic resection and a major operation.
And MRI has a special role for T-staging in the pelvis.
For sure. For rectal cancer, MRI's soft tissue contrast is unmatched for seeing if the tumor has broken through the bowel wall into the surrounding fatty tissue, the mesorectum. That finding is what decides if the patient needs preoperative radiotherapy.
Now, end stage, the lymph nodes. This is where imaging has traditionally been quite weak. Why is that?
Because we've had to rely on size. We'd call any node bigger than about a centimeter suspicious. But the problem is a big node can just be inflamed and benign, while a normal-sized node can be full of microscopic cancer. Size is a poor indicator of malignancy.
And this is where the functional boost from PT-CT comes in.
It's a game changer for nodal staging. PET looks for metabolic activity. Cancerous nodes light up because they're hypermetabolic, even if they're not enlarged. It's much more accurate than just measuring them.
Finally, M-stage metastases, looking for spread.
CT is the best for finding lung mets. For the liver, it's a mix of contrast-enhanced CT and MRI. MRI is probably slightly more accurate for finding very small liver lesions, and you have to map any lesions to the liver's Cournot segments to plan a safe resection.
And again, PT-CT has a huge role in finding hidden metastases.
A massive role. It can find occult spread to bones or distant lymph nodes that a standard CT would miss entirely, which can completely change the treatment from curative to palliative.
And the very last piece of the staging puzzle can happen in the operating room itself.
Intraoperative ultrasound. The surgeon can put a sterile probe directly onto the liver. The resolution is incredible, and it can find tiny nodules that you couldn't feel or see on the pre-op scans, ensuring a complete clearance.
Excellent. Let's wrap this up with our final key takeaway.
Key takeaway 7. Oncology imaging is a balance between fine anatomical detail for the T stage and functional assessment for the N and M stages, often using PT-CT. The goal is to get all the information needed to guide complex multimodal therapy.
Well, that brings us to the end of a really, really detailed deep dive. We've gone through Chapter 8 of Baily and Love. We've anchored the principles of ordering the right image. We've drilled down on the hazards. And we've covered the core applications of all the major modalities.
We've given you the anchors, the EGFR thresholds, the difference between deterministic and stochastic risk, the T1 for anatomy versus T2 for pathology rule in MRI, and the huge importance of functional imaging in oncology.
We've seen how these tools save lives in the trauma bay and completely define the treatment path in cancer. But they really do demand responsible stewardship.
So that brings us back to that final provocative thought. We know that whole-body CT in trauma is a lifesaver, but we also know that a single abdomen-pelvis CT is like 500 chest x-rays.
Yeah.
It carries a real, measurable long-term risk.
So the question for you to think about is, where do you draw that line? In a crisis, when you want every possible piece of information right now, how do you balance that immediate diagnostic certainty against minimizing the long-term stochastic risk, especially when your patient is young and has a whole lifetime ahead of them?
That daily balancing act, weighing the seen benefit against the unseen risk, is really the ethical core of what we do in medical imaging.
This deep dive, as always, is a starting line. It's not the finish line. To really make this knowledge your own, you have to go back to the source material, to Baily and Love, and you have to talk to your colleagues. Engage with the radiologists. Justify your choices.
Until next time, keep diving deep into the science that guides your practice.